Thank you very much for the opportunity to speak. Good morning. I have nothing to disclose. So really to get into the differences between the subtypes of achalasia, I want to start with a little anatomy and pathophysiology review. So the nerves involved with achalasia reside here in the myenteric plexus, sandwiched between the circular longitudinal fibers. We have both excitatory and inhibitory neurons. So what exactly happens to these neurons? The current understanding is that there's some initial insult, maybe a viral infection, that leads to inflammation in the myenteric plexus. And with chronic inflammation, eventually we get autoantibodies produced, and there's probably some genetic predisposition factored in here. With autoantibodies, eventually you get destruction of these nerves, and that leads to the disease state of achalasia. I also wanted to mention some of the differences at this level between EGJOO and achalasia. So there are known antineuronal autoantibodies in almost all patients with achalasia. We find these antibodies in only about a third of patients with EGJOO. But more different between the groups is the findings on muscle biopsies. So in achalasia, we have severe inflammation, there's fibrosis and elevated matrix metalloproteinases, and we see nearly, the ganglion cells are essentially absent, especially in advanced disease. EGJOO, there's no inflammation, no fibrosis, normal MMP expression, and you do see scarce ganglion cells with some morphologic changes. So the subtypes, what happens as we lose these neurons? So this image shows a normal esophagus with both inhibitory and excitatory neurons, and then on our little low resolution manometry tracing, we can see a normal propagation of a peristaltic wave and relaxation of the LES. So first we lose the inhibitory neurons, and this is type 2 achalasia, where we lose the inhibition of the LES, and we lose a propagation of peristalsis. Instead, there's pan-esophageal pressurization. And then the advanced phase of the disease, we have no contractility at all in the esophageal body. So type 2 to type 1 represents a progression of the same disease process. Type 3 is a little bit different. There are still ganglion cells present in type 3 muscle biopsies. Instead, we have a loss of function of these inhibitory nerves. And the original hypothesis back in the day was that type 3 probably represented the earliest stage of the disease. And there are some case reports out there of patients with type 3 achalasia progressing to type 2. However, there are more reports of patients with spastic achalasia persisting for over 15 years. And patients treated with Heller myotomy maintain spasms for many years after their treatment. So it's more likely that type 3 achalasia actually represents a less cytotoxic degree of autoimmunity, and it's a kind of a separate disease process from type 1 and type 2. So moving on to evaluation, we've got a couple tools. I'll quickly go over esophagram and our gold standard manometry, and then we'll go into Endoflip a little bit. I don't think there'll be too much redundancy here. So esophagram, we got our classic bird's beak appearance of the LES, and you can also evaluate the contour of the esophagus. As the disease progresses, we get more of that sigmoid shape with redundancy. And then timed barium esophagram we can use to compare the subtypes of achalasia and also kind of assess our pre and post treatment effect. On type 3 achalasia, we tend to see a more narrow column of barium, not surprisingly, and it does empty a little bit better than the other subtypes. But these differences we see on esophagram do not correlate to symptom severity. So this is a nice image of a normal swallow. We've covered this already, but just to review, LES relaxes, normal propagation of the peristaltic wave, and this is our basis for a Chicago classification. So really the big divider is the function of the LES as measured by integrated relaxation pressure. If that's too high, you move over to our disorders of EGJ outflow and our 3 types of achalasia here. So type 1, you need acontractility, no esophageal body activity at all. Type 2, you need some pan-esophageal pressurization. Type 3, some spastic early contractions. You can see failed peristalsis and some pan-esophageal pressurization and still have type 3. This is what that looks like on manometry. So we have no contractility at type 1, our pan-esophageal pressurization all at the same time for type 2, and these early spastic contractions in type 3. So how about EGD? A little case scenario here. Let's say you're doing an endoscopy for any reason, you find this. There's some retained food and fluid in the esophagus. Once you suck it out, there's some esophagitis, and when you get through the LES, you feel that pop. Can you diagnose achalasia at this time, or do you need to send your patient for manometry? you can probably diagnose it in some cases. So again, this is Endoflip, and I want to describe how this works a little bit. We've already kind of covered what the tracings look like, but this is essentially an impedance catheter inside a saline-filled balloon. And what it does is measuring the resistance between two sensors is dependent or correlates with the volume of saline around those two sensors. So we can measure resistance and then estimate the diameter of the tube at that level. And then taking the volumetric data, well, first of all, there's that topography you can see with a simple endoflip, kind of generates that data based on the resistance along the length of the catheter. And combining that volumetric data with the pressure within the balloon is how you get that distensibility number, where it's essentially a measure of how stretchy the thing is at that level. And the device always tells you the distensibility index at the most narrow point of the balloon. So this is all still under investigation. We saw some early data earlier, but it appears that you can, with good predictive value, find what an elevated IRP would be with Endoflip. So one paper that came out showed less than 0.8 for your distensibility index. It's a very, very high chance of a high IRP. So you can identify these patients in that group of EGJ outflow disorders. And the other thing that's nice about Endoflip is kind of the intraoperative usage. I just wanted to show this. So this is untreated achalasia. Here's they've done their Heller myotomy and then the door. So you can kind of monitor your progress, get some objective numbers to correlate with your progress in the operation, which is nice. So this is the LES. We can say a lot about the LES with Endoflip, but what about the esophageal body? This is where that panometry comes in. So we have learned that there are these predictable patterns of patients under sedation. And what we're really measuring is secondary peristalsis. So like we saw previously, these are normal patterns of secondary peristalsis in sedated patients, these retrograde contractions. And we do, when you see esophageal dysmotility, we saw some of those patterns already too. They can be retrograde or disordered. So using this device, seeing a tight LES with absent contractility, we can kind of figure out, this is probably achalasia. Can't really figure out type 1 or type 2. But type 3, there's a recent paper with a machine learning algorithm that can identify type 3 in 80% of cases. And this is a nice comparison of our achalasia subtypes and high-resolution manometry. So this is a sedated patient with the panometry type 2 achalasia. We see no contractile activity and a tight LES. And then on high-resolution manometry, expected panesophageal pressurization. And on type 3, we have tight LES in the retrograde contractions, and then expected findings on our high-resolution manometry. So you could make an argument that if you have these findings on panometry and the right clinical picture, you may be able to forego manometry. We don't have quite enough data to say that definitively. But you can also see some contractile activity and disordered contractions in patients with EGJ00 and achalasia. So if you have anything other than these findings, you still really have to do manometry to get your diagnosis. So a little bit on management. Type 1 and type 2, you really just have to address the LES. We have various tools to do that. I think going into the details of how to pick which treatment for which patient will be beyond the scope of this talk. But I did want to elaborate on type 3 a little bit. So you have to treat the LES and the spastic segment in type 3. And traditionally this is a difficult disease to treat. Over time we've learned a few things. First lesson was Heller myotomy is better than pneumatic dilation because you can get that myotomy higher up onto the esophagus. Then POEM came out and said, oh great, now we have a way to treat the entire spastic segment. And a few papers came out showing better results or better outcomes for patients with a long POEM rather than Heller myotomy. But now we're seeing more and more of these blown out myotomies. And there's a series out of Northwestern, they looked at 130 or 129 of their patients, and almost 18% of them had these blown out myotomies. And this is, patients come in with symptoms similar to dysphagia, and then you see this, it's actually a pseudodiverticulum that's symptomatic in these patients. And there's only a few case series out there about this so far, but I suspect this may play a role in the future. You can actually selectively do a partial thickness circular myotomy, and they're showing good outcomes after the procedure for the patient's symptomatic relief, and it's possible we're going to avoid these blown out myotomies with this approach. I think there may be a role in with Endoflip as well to kind of tailor the thickness of your myotomy to make sure you're doing enough. So in summary, type 2 achalasia progresses to type 1, autoimmune destruction of ganglion cells. Type 3 likely represents a less severe, non-cytotoxic degree of autoimmunity and is unlikely to progress. Endoflip with panometry can be performed at the time of endoscopy with a sedated patient and can reliably identify achalasia and differentiate type 3 in the majority of cases. Additional data and fine-tuning of these diagnostic algorithms may sometimes let us eliminate manometry from our workup, but that's to be determined. And stay tuned for partial thickness myotomies. I think we'll be hearing more about that. Thank you.